and welcome everyone joining us live, and I'll say hello to those who will be listening to us afterwards. Welcome to our special episode, Vaccines and Special Risk Groups, focus on older adults today. I'd like to introduce myself. My name is Lina Badr. I'm the FIP lead for Equity, Sustainability, Policy and Development. It is my pleasure today to be chairing and hosting this event for you. I'd like to start with very quick housekeeping announcements. Just a quick reminder, hopefully you've all been attending our FIP webinars. This webinar, as with all of our other ones, is being recorded and live streamed via YouTube. The recording will also be available on our website, events.fib.org. You may feel free to ask questions using the question box provided and the toolbar at the bottom. And of course, feel free to provide any feedback you have using the email address you see on screen. And if you're not already a member of FIP, find out all about our membership benefits by going online www.fip.org. One more announcement from me today. Our esteemed speakers will be delivering their presentations in English, but we are pleased to offer live translation in French through this Zoom window. You can access the translation through clicking the interpretation icon. It looks like a little globe at the bottom of the toolbar. I'd like to also start by acknowledging Sanofi, who have provided unrestricted funds to help us deliver this event for you today. Thank you, Sanofi. Some bigger contexts, we'd just like to, if you're not aware, we'd like to just point out some really important timelines we're in. So the UN Decade of Healthy Aging from 2021 to 2023 was bestowed in 2020 by the World Health Organization and the United Nations member states. And this is really to ensure that all older adults can live long and healthy lives. And this has been formally known as the UN Decade of Healthy Aging. And it will focus on the 4 action areas that you can see on the screen: changing how we think, feel, and act towards age and aging, ensure that the communities foster the abilities of older adults, deliver people-centered care and primary health services that are responsive and catered to older people, and last but not least, providing access to long-term care for older adults who need it. We're also tomorrow going to be globally celebrating the International Day of Older Persons, also a UN day that strengthens the advocacy for this special group of people and patients. So congratulations on that, and we're very pleased to be delivering this webinar around that anniversary. We'd also like to say that our focus on older adults is not new. We have plenty of activities deliverables in the past. I'm just pointing out a couple of recent ones. As early as last year, we had a full interview with the International Federation of Aging Secretary General Jane Barrett. And I know we have a representation from that very organization today. We will be introducing our speakers later, where we have delved deep into the issues of access to vaccination specifically for older adults. I'd like to also say that this specific episode is delivered within a 4-episode series focusing on vaccines and special risk groups. We've already delivered 2, one focused on cardiovascular diseases and another on chronic respiratory diseases. Today is the 3rd episode, and we will be announcing the next episode at the end of this webinar. And last but not least, I'd like to very briefly welcome all of our panelists: Jean-Pierre Michel from University of Geneva, David Sinclair from the International Longevity Center, Katrina Bouzanis from the International Federation of Aging, and Martine Rugli from Pharmacists. I'll be introducing each one in due time. Very quickly, how will today run? So this is my introduction, about to end, but we will be starting with a contextual presentation to set the scene about vaccination needs and benefits for older adults by Professor Jean-Pierre Michel. Then we will be joined by all the other panelists for a panel discussion and Q&A, and we will be taking up some questions from the audience, from you. So please feel free to drop in your questions the moment you think of them, and we will do our best to pick them up later during the panel discussion and Q&A. what are we here to do today? So learning objectives. At the end of this event, we really would hope that you have a better understanding of the most important vaccines for older adults. Recognize, of course, importantly, the role of pharmacists in promoting vaccinations to the elderly, and discuss and identify some strategies that can support the promotion of a life course approach to vaccination across all life ages and stages. So, without further ado, I'd really like to welcome Professor Jean-Pierre Michel. Professor Jean-Pierre Michel was Professor of Medicine and Chairman of the Academic Geriatric Department in Geneva University Hospitals until 2011. Then he was also President of the European Geriatric Medicine Society, while acting as the World Health Organization expert on Aging and Life Course Program. He is a full member of the French Academy of Medicine and foreign member of the Royal Academy of Medicine of Spain. Professor Jean-Pierre Michel, welcome to the stage. The floor is yours.
Thank you very much. I will try to share my screen first. Take 1 minute. My arrow is not very friendly with me today. Okay. So good morning, good afternoon, good evening. It's my pleasure to be with you today, and I would like to thank Gonzalo and also Ruben for inviting me to this very important event. So my today lectures will be, cannot start. My today lecture is on vaccines in old adult, and I have no conflict of interest. The first thing that I would like to tell you, and what's just said by Lina, is that I cannot speak about adult vaccination without thinking about the life course approach. And what is very important for me is to tell you that life starts at conception and finish more and more in the old age. And indeed, we have this life trajectory as two components. The first one is that we have individual characteristic and we have life environment characteristic. And our life is, all our trajectories is managed by these two characteristics. And when we are thinking about vaccine and the positive impact of vaccine, we have not only to think about the old age, but we have also to think of life trajectory. And indeed, vaccine can help healthy aging. And I hope that you will understand why I am thinking it. So today, for this lecture, I would like to cope with different topics. The first one is I would like to remind you that infectious effect of vaccine was very well proven and are really fantastic event in public health. The second thing is that I will speak about the global immunization on global health in adult, and I will probably give you a new information concerning this aspect. Thirdly, I will try to tell you that, in fact, old and vulnerable adult vaccines is very challenging. And indeed, we will see how we can cope with this. And then I will try to leave you with a few take-home messages. So I hope that you are in agreement with my program, and I will start by the short history of anti-infectious effect of vaccine. The first thing which is very important to have in mind, if we are comparing in different countries or in different continents, Australia, Canada, United Kingdom, and USA, the effect of vaccine on morbidity and mortality, you are sure that to find very good results. Concerning all the classical vaccine, you can see that for congenital rubella, for diphtheria, Haemophilus influenzae, measles, mumps, pertussis, rubella, tetanus, the decrease of the incidence of the disease was above 90%. So 90% of decrease of the incidence of this disease. And more than that, we can say that for smallpox and poliomyelitis, these two diseases were eradicated. And to start, I would like to show you that for smallpox was eradicated with one big effort of WHO and in 1980. But what is very important, the only things that you have to have in mind is that this eradication was possible because 100% of people get the vaccine, which is something that we have to keep in mind. And for poliomyelitis, it is quite exactly the same. The disease was partially eradicated in 2016. There are always a few countries with few cases of poliomyelitis, but another time, for the most important countries in the world, the decrease of the disease and the eradication of the disease is linked to 100% uptake of the vaccine. So WHO said that vaccines have saved more than 500 million of lives in the past 50 years. And currently, WHO estimates that every year, vaccines save around 4 million lives, which is fantastic when we know that the vaccine coverage rate is not so high. When we are speaking about COVID, I think that there is another time, show that vaccine was very effective. Vaccine prevented around 40.4 million deaths from COVID in 185 countries and territories. So the estimated efficacy of COVID vaccine was around 63%. Fantastic. And indeed, we can recall this very nice sentence from Plotkin that the history of vaccine have been the medical intervention with the greatest beneficial impact on human health and longevity. The second point is the impact of immunization on global health in adults. The first thing that I would like to stress again is that today in the world, we have more adults over the age of 65 than children below the age of 5. And the number of adults over the age of 65 will pass from 7 million in 2020 to 1.5 billion in 2050. So we will double the number of population over the age of 65 in the next 30 years. And when we are looking at the burden of infectious disease, something is very striking, is that today we have more deaths from preventable vaccine disease in adult and old adult than in children. And the difference is very, very important. More than 300 more times more deaths in adults from vaccine preventable disease than in children. And this is striking and reflecting probably a number of underlying structural, economic, cultural, and political issues. And it is for this reason that we have to speak of a life course vaccination program and not only a program for all adults. I will show you one interesting data concerning pneumococcal disease. And when we are looking at pneumococcal disease, you can see that two categories of persons are involved. The young adult before the age of 5 are indeed the target population and a lot of deaths, but also the adult over the age of 65. So when the pneumococcal vaccine 7 was introduced in the state in 1988, you can see that we had the vaccine decrease the incidence and prevalence of invasive pneumococcal disease in children, but by the same way, we had a decrease of pneumococcal disease, invasive pneumococcal disease in adults. And that show that, in fact, there is a kind of interaction between children and old adult, and infant vaccination may indirectly protect the old adult, which is very surprising, but very interesting, because it is a two-way action. And in fact, it was also the case for pertussis, meningococcis, tuberculosis, COVID, and there is this kind of translation of and transmission of disease from adult and children to adult. And what is something that was awful is that even if we have a vaccine today, and we are looking at, in Europe, at the confirmed invasive pneumococcal disease, we can see that there is no decrease in the incidence and death from invasive pneumococcal disease in children below the age of 5 and above the age of 65. So that is to say that we have good vaccine, but they are not used. So another thing which is striking for me as a geriatrician is in fact the possible contamination and transmission of disease from healthcare professional to the old adult. And this is a very nice French study which was done in the Paris area, including 3,600 nursing home residents. Half of them get the vaccine, half of them did not get the vaccine. And the authors are a very nice idea. They look at the global cause of death in this population of residents of nursing home, comparing the staff coverage rate of flu vaccine. And in a few nursing homes, the coverage rate was quite low. And in other nursing homes, the coverage was quite high. And what is very surprising is that, in fact, there is a decrease of all cause of mortality in the nursing home where the healthcare staff are vaccinated and with a higher level of vaccine uptake, which is to say that if we have to send or to have an old patient admitted in nursing home, your advice has to be to go into the nursing home where the healthcare staff is more vaccinated. So we have not to forget this, and we have also to think that it is not for only this reason that we have to vaccinate all adults. The first thing that is important to notice, and which is not well known, is that after any infectious disease, you can have a decrease in functional abilities. And infectious disease are considered as the sixth cause of disability in old adults. And looking at this data, very recent data concerning disability adjusted life here, you can see that influenza vaccination are a main cause of disability adjusted life years of dailies. And indeed, you can see that also pneumococcal disease after the vaccination, after this disease, have a lot of incidence on disability. So we have not to forget that infectious disease are increasing functional disability. The second thing is that, in fact, we are not given enough attention to all cardio and neurovascular events in the old population. And vaccine has a lot of role in this way. I will give you a lot of information concerning systematic review of 12,000 patients who comparing people who got the vaccine and not got the vaccine. It was general patient, not selected patient. You can see that in this population, the decrease of mortality in vaccination is very, very important, more than 50%. If we are now considering patients with coronary heart disease, if comparing always placebo-controlled people with vaccine people, the decrease in myocardial infarction in this population raised to 60%. 67%. If we are now considering, and it is very important, heart failure patient, we can see that whatever the age of heart failure patient, if the people who got vaccine decrease their all-cause of mortality by 30%. And if we are having also the global population, and vaccination is a global population compared to control population, there is a decrease by 20% of the risk of stroke. So this is well known. It was proposed in the state and the American Heart Society in 1986, but it is not applied and not known. Influenza vaccine protect again a lot of arteriosclerosis complication. More than that, if we are looking at diabetic patient and taking also flu vaccine, these persons who are vaccinated have low pneumonia, low respiratory failure, have low admission in intensive care unit, and also it was very significant. And it is exactly for when we are studying all patients with diabetes, and we follow them during 2002 and 2005, and you can see that the all-cause of mortality decreased by 33%. If we are now considering as a kind of chronic disease, as COPD or chronic kidney disease, we have exactly the same kind of effect with a significant decrease of coronary acute syndrome. And to last, I would like to tell you that pneumococcal vaccine is less active on cardiovascular disease, but it is something that has to be noted. And also, herpes zoster vaccine protects against the incidence of strokes. So, to last, we know quite well that hepatitis vaccine decreases the risk of developing diabetes. And even if I have to speak about old adults, I have to tell you that rotavirus vaccine in children now decrease diabetes type 1 by 20 to 30%. And it was done and demonstrated in court from Australia and USA. And to last, I would like to tell you that we published recently with my colleague Nicola Veronese and Stefania Maggis this study concerning the impact of flu vaccine on dementia. Nothing is really very proven, but in fact, when we are looking at all the publications concerning around 300,000 patients free of dementia at the start of the study, and these patients were followed during 9 years, you can see the decrease of dementia onset was very impressive, less than 30%. These data need to be confirmed, but they are very, very encouraging for having vaccine in old adults. The third point that I would like to notice now is that, in fact, when we are speaking about nature, surrounding, ecology, we have to think that vaccine also protect and have very important impact on antimicrobial benefit. We have to know that in Europe, approximately 33,000 people die every year of a resistant infection. And in fact, when you are comparing antibiotic and vaccine, you know quite well that resistance is a crucial problem for antibiotics, but it is not a crucial problem for vaccine. And when another time, I go back to the pneumococcal vaccine, and when the pneumococcal vaccine was introduced in the state in 2010, pneumococcal conjugate vaccine 13 introduced in the state in 2010, you can see that the decrease in antibiotic resistance was very, very impressive, because we have decrease of resistance of microorganisms by 60%, but also cephalosporin, tetracycline, penicillin by 80%. So using vaccine decrease the number of antibiotic prescription, but also by a personal effect have antimicrobial effect. So when we are considering this point, I think that we have to think that decreasing antibiotic prescription, decreasing resistant infection have to be now considered as new positive outcome of vaccine. And we have more and more to think in a new way, which is to consider what health, which is the link between human health, animal health, and environmental health. And when we are thinking it, you have to think about all the antibiotic given to animals. So I think that vaccine will have a very important role in the near future for protecting everyone. Now, indeed, we have challenges. We have challenges for vaccinating old and vulnerable adults. And when we are looking at these problems, we have to think about immunosenescence, we have to think about inflammation, we have to think about malnutrition. You know that with aging, we have less effective barriers, skin barrier, less mucus, less saliva. We have frailty people, we have multimorbid people, we have polypharmacy. And what is very not understandable is that, in fact, also the older adults are disproportionately affected by the infectious disease. They are not or not enoughly integrated into the vaccine trials. And indeed, we have the chance to have future vaccines which are very active in old adults because we use new adjuvant, and the best things to understand is, for example, the new herpes zoster vaccine. And we have also RNA vaccine, who in fact are as effective in old adults than in young adults. And at that time, the main problem is the vaccine uptake. And when you are looking at the uptake of the flu vaccine in Europe before the COVID pandemics, you can see that WHO recommends in all the European countries to have a coverage rate of 75% for the adult over the age of 65. And very, very few countries try to get this level of 75. But all the other countries don't have this level of coverage rate. And indeed, when we are looking in details of that, you can see that older adults are below the WHO level. Indeed, the chronic ill patient, but also the old chronic patient do not get the level recommended by WHO. And what is a pity is that the healthcare workers are not vaccinated and did not get the vaccine. So I will not insist on vaccine hesitancy because I will speak 1 hour on this topic, but we have to know that there are different causes. There are indeed personal and social influences. We have also contextual influences, and we have also vaccine-related determinants. I will not insist on that because I think that for all people, I think that we have to think that despite the public of health triumphs of vaccine, or perhaps because of the vaccine triumphs, the ravages of vaccine-preventable disease have been forgotten by our old colleagues and people. And in fact, what is now the emerging problems, the fear of vaccine, the decreased confidence of vaccine, and the decrease in vaccine delivery system. So more than that, there is a close relationship between the law of rumors and the decrease in trust in vaccine. And indeed, all of us, including pharmacists, has to participate in an educational effort. And we need to give to all the population trustful, updated information concerning health. And particularly, we need to involve all the healthcare professionals in this way. How to conclude this take-home message? As I told you, I cannot speak only of old age vaccination because I think it's not enough. We have to think of vaccination of children, and these vaccination of children are now very well known. The efficacy are well known, the scientific basis are well known, and there is less problem than in the future. But today, we have problem with the old age vaccination. Second point, we have a lot of lack of recommendation for the adult. At midlife, there is no recommendation, and people do not take vaccine. Why? They will have better healthy aging by getting vaccine. And we have more and more scientific knowledge to say that it is true. The third point is that we have very good and precise recommendation for adults with chronic diseases. But in fact, different kind of specialists, GPs, but also cardiologists, diabetologists, respiratory disease are not applying the rules and the knowledge that we have on this. The last point is that we need for all the vaccine to have more harmonized recommendation. We don't have harmonized recommendation. I try to do a lot of things to promote this harmonization, but it's very difficult because every country or each country has its own law, has its own reimbursement. It's very complicated. But what we have to keep in mind that all adults will benefit of influenza, pneumococcal vaccine, COVID vaccine, tetanus and pertussis vaccine, and shingles. They are the most important vaccines that we have to give. And we know now, after the WHO recommendation, that it is possible to inject at the same time COVID and influenza vaccine, COVID and pneumococcal vaccine, which is very important. This is a new WHO recommendation. But what is the main problem is that we need to improve vaccine uptake. And we need to improve vaccine uptake at any age. And it is an urgent need. And your role as pharmacists is very important. And personally, I would like to thank you for all the effort you did to improve education, to improve uptake, and also to improve delivery of vaccine for the whole population. And with that, I would like to thank you for your attention.
Thank you very much for that, Jean-Pierre. I certainly was listening really attentively and taking notes. And I just wanted to relay some of those things you just mentioned. Some of those facts were even very important and I found really surprising in some instances. So thank you for giving us a short history of the effects of vaccines on reducing infections and of course the mortality and morbidity related to that, but also the ripple effect of vaccines on older adults in reducing risks of other conditions, disability related to vaccines. You mentioned chronic conditions as well as dementia and the risk of that, and also its links to reducing antibiotic resistance and improving its use for public health. It was very also important to listen to how the vaccination of people around older adults had a direct impact on their own immunity. And I think that's a very important fact. And that study from the care home was very, very important, as you had pointed out. Thank you for pointing out some of the challenges to the uptake as well. It's very important, as you mentioned, to think of older adults in a holistic way and all of the issues they face and how vaccines fit within that, and the role of healthcare professionals in reducing vaccine hesitancy and improving older adult confidence in vaccines. That was really, really informative. And I'd like to thank you so much for that. I know we'll be receiving some questions which we will be addressing shortly, but I'd like to now move us to the panel discussion section of our webinar. And without further ado, I'd like to start introducing our other esteemed panelists. I'd like to welcome David Sinclair, Chief Executive of the International Longevity Centre in the UK. The International Longevity Centre, along with our other organisation represented today, is very much obviously focused on advocacy for this special group of people. David has worked in policy and research on aging for 20 years and presented on the topic across the world. He has strong knowledge of not only UK, but also global aging society issues, from healthcare to pensions, from housing to transport. So a very holistic overview. David, welcome. Thank you so much for joining us. And I'll ask you to turn your camera on. Thank you so much for being with us.
Hello, hello.
Hello, thank you so much, David. I'd like to then introduce our other panelists. Katrina Buzanis. Katrina is a graduate from McMaster University. She has a master's in global health and holds a bachelor in microbiology and immunology with honors from Dalhousie University in Canada. Since joining the International Federation of Aging, she has worked across various projects with the goal of improving uptake and access to vaccination for older adults. Spot on topic, Katrina. Thank you so much for being with us today. We welcome you on this panel, and I'd like to ask you to turn your camera on ahead of the discussion.
Hi, thank you. Happy to be joining today.
Thanks, Katrina. And last but not least, representing pharmacy and one of the leading national organizations of pharmacy on a national level from Pharmacists, Martine Rugli. Martine Rugli has been the president of Pharmacists, which is the Swiss Association of Pharmacists since January 2021. She has held this post. Before this position, she had been the coordinator of strategic projects at OFAC, which is the professional cooperative of Swiss pharmacists, and the head of innovation and international affairs at Pharmacists from 2017 to 2019, and the head of the Department of Collaborative Practice from 2012 to 2017, where she developed innovative services such as Netcare, the quality circles, and pharmaceutical care in nursing homes. Welcome, Martine, and thank you so much for joining us.
Thank you for inviting me. Hello, everyone.
Hello. I'd like to also ask Jean-Pierre to come back on camera, and we can, I think, turn off slides and just focus on our lovely speakers with us today. And we ended, Jean-Pierre ended his presentation with obviously all of his own perspectives, all backed by evidence and science, but we'd like to hear from you. And perhaps I'll start with our representatives from the advocacy organizations for older adults. And maybe I'll start with Katrina, with what is your perspective from, as IFA on the current uptake of vaccines in the special risk group of older adults?
Yeah, thank you for that. And also thank you to Professor Michel for that presentation, which was quite a nice overview of the state of vaccination in older adults and just what a benefit it has on healthy aging, which is something that we know. Yet we also know that vaccination uptake is very poor in this group. It's entirely suboptimal for a number of reasons related to kind of some of the things that Professor Michel alluded to. Firstly, starting off with very lackluster policy and recommendations in this group, if we kind of think about it from the top down, but then going all the way down to kind of a lack of education and awareness, a lack of targeted messaging, a lack of considerations of some of the special circumstances that we see in this group of older adults, things like, potentially dealing with other chronic comorbidities, not having a caregiver, being a little bit more dependent or socially isolated, things like that, that really kind of inhibit people from navigating through vaccination pathways, which we know for older adults and for all adults in general are not as straightforward as we have in childhood immunization. So let's start there. That's a starting point.
Thanks. That's a good one. We have a lot to talk about, so thanks, Katrina. I'm going to go to David. What are your perspectives from the ILC, David, on this issue?
Great, thanks. And let me first say thank you to all of the pharmacists on the line. Having, as someone who's literally this morning just popped in to have my flu jab in my local pharmacy, and I have to say I was in there probably 4 minutes at the most, 3 minutes of which they were typing my details into the computer. So astonishingly wonderful, wonderful experience, and really great. So thank you to all the pharmacists out there who are involved in doing that. I suppose for us, the research we've done this year paints sort of a picture similar to what we've heard from Jean-Michel and others. We know, for example, flu vaccine in UK adults with underlying health conditions, uptake is only about 57%, way below the target, and pneumococcal vaccination in risk groups even lower, sort of 4 in 10 people with risk groups have it in risk groups taking up their right. And then if you look at people in risk groups who happen to not be white, from the UK, you see very significant issues. So, for example, at-risk Asian or Asian British Pakistanis, you've only set 4 in 10 people have their flu vaccine. So very significant issues in the UK. But then if you look across the whole of Europe, you see very similar pictures. So in fact, actually worse. Across the whole of Europe, only 1 in 4 European adults living with 2 or more conditions. 25% of adults living with two or more chronic conditions, very few of them have received their flu vaccine, and the same with pneumococcal. So essentially, it's a very long rambling way of me saying that clearly there is a massive issue with uptake in both the UK and then across Europe as a whole. And I think there are 4 major issues, and I won't go into any detail because we could perhaps talk about them later. One is communications and communication barriers. One is sort of structural barriers. Issues around discrimination from healthcare providers are really important. For some of us, we have personal factors, whether they be needle phobias or conflicts with individual choice, and then there's accessibility issues, for example, the physical and geographical barriers. And I think pharmacy in particular has a very strong role to play there. The reason I went into my pharmacy today was because frankly it was much easier to get to than it is to get to my GP and book an appointment. So I'll stop there, but happy to go into more detail on that if we want after.
Thanks so much, David. And I know we'll delve a little bit deeper into these barriers. So thanks for kickstarting that. I'm going to go to Martine very quickly. Martine, what are your perspectives on uptake in this group?
I think that the big problem that we have to face for pharmacists is the acceptance from the governments or from the physicians that we pharmacists vaccine the older adults. In pharmacy in Switzerland, actually, we had a big issue because the physician, and I know it's not the only country, the physician didn't want the pharmacist to vaccinate. And for the acceptance of the vaccination of the pharmacist, we started to say, okay, we want to enhance the number of persons that are vaccinated. And we start with the healthy adults. And like that, you can penetrate on the vaccination and you can have your first role. And when that is very well established, then you can go further. So that's the big difficulty, I think, for the pharmacist, is the government in many countries don't allow us to vaccinate all the adults. So now in Switzerland, we have vaccines since 2016. So we have already 6 years. And now we are starting to be discussing because in Switzerland, it's not a national basis. It's every region can decide what they want. So we start to discuss in each region also to have the older adults. What we did, and that helps, is we did also a survey in Switzerland to know how many older adults were not vaccinated, even in they have chronic conditions. And so showing that, then we can go to the local governments and say, see, even if they are followed by a doctor, they don't get their vaccination. So start slow to be able to arrive. But that's the problem.
Thanks, Martine. I think that's a really important point for how to influence policy to allow pharmacists to vaccinate and increase uptake. And I know we'll discuss that and the role of pharmacists in a couple of questions more. But before wrapping up and going to the other question I have, I wanted to go back to Jean-Pierre. Jean-Pierre, you touched on the variation across countries in terms of uptake and how that varies globally. But also we just heard from David about also within a country, there are different uptake rates, and we can see how the issues of inequities and access to care affect different communities. What are your thoughts and comments on that?
I think that David was completely right. The problem of discrimination of health inequities are very high, and health inequities are also linked to other kind of inequities, social and economic inequities. And also the main problem for us, for people who are doing vaccine, is to reach the old age, but also the most vulnerable, and to also reach the out of reach people, which is really something that we are starting to do, or a few countries are starting to do, but it's very complicated. And once again, I would like to say that David was completely right, saying that pharmacists completely change the panorama of vaccination in many, many countries. And we have to thank you.
Thank you so much, John. And I know, there's also the issue of how the COVID pandemic and vaccinations of that may have completely shaped the agenda and maybe accelerated pharmacy-based vaccination. That's a whole other topic. So, David, you touched on some of the barriers, and you listed 4 barriers: communication, some structural barriers, personal accessibility. Which ones of these would you say are most critical, or with the highest influence or impact in the UK, for example?
I think it's worth saying that many of them are the same across the world. Actually, it's a very, the issues are fundamentally the same. For me, I think one of the, the biggest one is actually this issue around accessibility. And that's where I think pharmacists have an extraordinarily important role to play. Sort of, making sure that vaccinations aren't too expensive, that you have flexible appointments. So I think actually that I think as someone said once, if they build it, people will come. They'll actually the reality is that we've got to, the first thing is we have to offer it. I think the other thing, I think we probably shouldn't underplay some of the issues of the fact that particularly for most at-risk groups, there's a lack of clear and unequivocal information about why it's important to them. So for example, it's actually really hard, again, as someone who's just been in for my winter flu jab, the list of different conditions that allows me to get that free as part of the NHS is extraordinarily long and not something I'm likely to know. So how do we keep people informed about, if you have condition X, you should make sure you're being vaccinated? It's very hard. And then I think alongside that, the third point I would emphasize is there is still discrimination for people who are in at-risk groups. So to give you a couple of examples, some of the research we did last year showed that or one very particular one, we did some interviews with some people who had HIV, and found that there was significant discrimination of people with HIV within the healthcare system, and we had, to the extent to which we had one individual with HIV who, when he started talking about having it, he was asked whether he should even be allowed to work with his condition, which put him off seeking vaccination from a GP surgery. So we need to make sure that we're not sort of discriminating against people, and we know that, for example, so for example, and I think there's I guess a lesson here for pharmacists as well, that if, for example, HIV is one of the risk groups, one of the real issues for an individual might be they might not want to tell a receptionist this. So how do you or someone on the counter, so how do you manage people actually telling you that you might have HIV or cancer or a condition that allowed you to have a vaccine without actually doing it in a fairly public environment. So, so I think there's a really important question there for pharmacists.
Maybe I can answer that. And of course, the vaccination is never, ever done in the front. You always have a consultation room. And we also have like an algorithm that we are discussing with the patient before we vaccinate. And we ask for chronic condition, we ask for condition. So of course, it's never, ever done in the pharmacy. It's in Switzerland, at least, it's a requirement that is actually mandatory for every pharmacy. And even during COVID, we had even to have separate rooms, not even in the pharmacy. So that's no problem at all. It's never done in the middle of the pharmacy, at least in Europe, because I discussed with different in Europe and they say it's the same.
Thanks, Martine. But I think that's really important topic.
Yeah.
Stigmatizing diseases is an issue.
No.
We're already facing issues with health literacy and making sure patients understand what healthcare services they have access to. So Katrina, from your expertise as obviously a program manager on vaccines in older adults, so that intersection is so important. What are the barriers from your point of view in uptake?
Yeah, I think I'll touch on a lot of the same things that David just mentioned, which is, I suppose if we kind of start top down, the policy is quite confusing, as David mentioned. It's hard to, in some cases you are paying out of pocket, in some cases you need a prescription from a doctor before you can even start to think about getting your vaccination, and this hugely varies across the world. But then of course, in Europe, in Canada where I live, the policies are actually quite good, and there are many countries where the policies are almost non-existent and older adults are not included in national immunization plans at all. So that's a starting point where there, as part of every country's national immunization plan, there likely should be a section on older adults, as opposed to just having that being limited to childhood vaccination as it sometimes is. And that also starts with kind of the advisory groups that make those decisions, having the gerontologist on to represent older people and to speak to the importance of vaccination and the benefits and be part of that decision-making process. So that's, a high level kind of policy thing, but then that also very much trickles down into a lot of the very practical things that David was mentioning, which is, how do you understand those, with those recommendations? Are you aware that you need to be vaccinated? Which I think it's safe to say that there's not a lot of good targeted education towards older people, specifically thinking about the channels that older adults might seek information on. So that's an issue. And then even if you want to be vaccinated, there are many practical things that go into actually getting to the place where you can receive your vaccination. And so, as we've all been mentioning, pharmacists are quite beneficial in that way because they're in communities, and it's much easier to get to a pharmacist than it oftentimes is to get to a physician, a GP. So I think the infrastructure is poor in that sense, in that it's very, very hard. We don't have that same sort of knowledge around where do I go to be vaccinated, particularly if you're living outside of kind of urban centers and things like that. And particularly when there's a cost associated with it, or when there's fear of a cost being associated with it. So sometimes people don't even know that things are free. So those are some of the things.
Thanks, Katrina. This made me think of some discussions we've been having at FIP that link to health literacy and inclusivity, and some points were made about too much information also leads to health literacy, and when there is information overload, that makes it hard for people to find the right kind of information as well. And I agree with your point about there need to be tailored communication strategies with older adults and understanding the best ways to communicate with them, and that should trickle down to the pharmacy level. Jean-Pierre, you mentioned and obviously explained a little bit about one of the biggest barriers, vaccine hesitancy. Could you tell us a little bit more about, from your expertise, what is the maybe top 3 ways we should be tackling vaccine hesitancy in older adults, besides reminding them of the ravaging effect of public health diseases in the past? But what are maybe your top 3 recommendations?
It's a very complicated issue, because I think that one main problem, and I'm completely in accordance with Katrina, is a problem of education, and on basic education indeed, but also health literacy. It is that how to get information, how to be able to understand the information, how to think about and have a reflection on thinking about the information to know if it is right or not right before any decision. And I think that the hesitancy is linked to a lot of factors. Indeed, personal factors, and I think that education are very important, but also sometimes the belief of being too strong to need any vaccines, or don't think that once we will be able to get the flu vaccine or the COVID. So there is something in the personal issue. The second point, which is also very important, is in fact the problem of the social environment, the family environment, the colleague support, and also the trust and not trust, as it was said before, with the government and with the health policy of this government. And the main problem in this way that is also linked to the vaccine-related determinant is the fact that we had a lot of people had a lot of information, and sometimes false information were repeated and repeated. And when false information on this leaving information are repeated, people are thinking that they are right. And I think that for example, one information concerning the RNA vaccine, which was completely stupid. Yes, the vaccine was developed in 1 year, but before the 1 year development of vaccine, there were 60 years of research to develop the vaccine. So there is something, and which is very important. And also perhaps something that was mentioned also by Katrina is a problem of the cost, but also, as you said, the problem of accessibility. And as I said before, I think people who are alone, all people who are alone at home or out-risk people need to be also targeted. And I think that it would be a very important way. So vaccine hesitancy is a main domain, and we can find all the main issues. But in fact, something which stressed me a lot is that, in fact, I don't understand why healthcare professionals are not really aware about the benefit of vaccines. There is something that I don't understand, because so when we are thinking about medicine, for example, we heard about vaccine only at the end of after having a talk on one disease, we heard about vaccine, but we don't have any global aspect of vaccine. And I think it is exactly the same in nursing school or in other healthcare professional school. There are no topics related to the vaccine, global vaccination. And indeed, pediatricians are doing a good job, but now other professionals has to do the job for other ages in the life course.
Thank you so much, Jean-Pierre. I think that's a really important point, is the confidence of healthcare professionals themselves in vaccines. And if that's not at 100%, then we're in trouble. I want to go to Katrina very quickly, and Martine, I'll come back to you in a moment, because we want to talk about pharmacy. But this is really good, because these are the common general issues that affect everyone. But Katrina, what do you know about vaccine hesitancy in older adults? Tell us what you have on that.
Yeah, well, actually, just to pick up on Professor Michel's point, we actually it seems that healthcare professionals actually have a lower rate of vaccination than the general public, which is, I mean, quite concerning, frankly, because these are, we know that people consider healthcare professionals one of their main sources of information on vaccination. So that's definitely a concerning kind of point. In older adults, I think we definitely tend to almost wrongly lump people into two groups, either pro-vaccine or anti-vaccine. And the truth is there's a big spectrum in between that of people who are just confused and don't necessarily have the right information or, a high level of kind of health literacy to sift through the mountain of information that there is on vaccination, particularly considering, there's at least 4 or 5 vaccinations that should be recommended for older people. There's different types of vaccines within that. There's different timing of doses. There's different ages that, that are recommended across different jurisdictions. So it's confusing. And so I think sometimes we tend to discount the people that are just confused and lump them together with people that are anti-vaccine. And so I think that's one thing to recognize. And then I suppose the other part of that is having kind of education that really helps to actually address the specific concerns, fears of that group, the specific needs of older adults, things that are really targeted to the person, I think is particularly helpful when addressing vaccine hesitancy. So there's that. And then I'll also just kind of add that part of vaccine hesitancy is also some of the practical things that keep you from being vaccinated as well. So that's also kind of another layer to address. So I think I would just kind of discourage this idea that I think education is really kind of the answer and communication is really kind of the answer, but it's also, I think, needs to be communicated in a way that's not necessarily the way that physicians have kind of traditionally gone about it in the past. I think there's kind of changes that are needed in that sense to think about storytelling, addressing kind of emotional fears and emotional thinking that often goes into that decision to being vaccinated.
Thank you, Katrina. I think that's a really important point. We tend to sometimes oversimplify vaccine hesitancy, and you're completely right on that. It's not one of these groups. There's a spectrum, and there's the issue of complacency, which Pierre had on his slides. Confidence is one, but also convenience and how easy is vaccine access, and all of these probably have to be playing together at really high levels. And I think when it comes to older adults, convenience and access is a very, very critical pathway. Thank you for that. I'll go to David, then Martine to talk about pharmacy. But David, what about vaccine hesitancy in older adults in the UK? Do you have any data or insights into that you can share?
Yeah, we last winter we did a major piece of research supported by Meta, by Facebook, that and the idea was, what we wanted to do was explore whether or not you could engage younger people or engage older people via Facebook by, in effect, asking younger people to share information with them. And we did this campaign that we used real people. We got lots of evidence about what works, and actually our campaign, which we ran over Christmas, we actually had over 1 million people who engaged with the campaign. So real engagement. And one of the motivations for doing this was because we knew that amongst risk groups and ethnic minority groups, there was certainly a concern about issues around whether misinformation was more likely in some of these groups. Now, one of the really interesting things that we found was that, and I think this is where we have to actually, be really careful not to sort of, underplay the expertise of the general public. So we had a very big debate about whether we removed comments on the Facebook advert. And clearly, as you can imagine, when you've got 1 million people, you're talking about thousands and thousands of comments. And one of the things that was really interesting is you would get one person giving a piece of misinformation, and we debated whether we just deleted this and decided not to. But actually, we would have 10 people who were ordinary members of the public who said that's nonsense, that's wrong because of X. And actually, it was pretty self-regulating that actually the public themselves, certainly in the UK, and this was deprived communities in the UK, just didn't buy it. The number of people who believed the misinformation were a real minority, and it was often, and I think we have to sort of almost not overplay this, but actually give the champions access to information so they can respond to those Facebook posts themselves.
David, and I just wanted to point out, my colleague Roman has just put in the chat.
We don't hear you very well.
Can you hear me now?
Yes, better.
Sorry about that. Thanks, Jean-Pierre. So we just put in the chat a link to a toolkit we've developed at FIP, Building Vaccine Confidence and Communicating Vaccine Value. For any of those listening, it's a toolkit for pharmacists that you can use on the ground. So let's talk a little bit more about pharmacy and the role of pharmacy. And that's really why we're here. Obviously, we all agree pharmacy-based vaccinations widen access to vaccines. They do tackle the issue of convenience and accessibility. So this is especially important for the older adults. So Martine, how can pharmacists better promote vaccination in this group of older adults?
I think everything that was said was absolutely correctly. We have to sensibilize the importance of vaccination. And the presentation from Professor Jean-Pierre Michel was excellent in that point, because if you can explain to people what happened if you get vaccinated, what helps for your health, that's very important. And just an example, not from Switzerland, but from Belgium. In Belgium, during the COVID, the pharmacies were not allowed to vaccinate, but the government had like in central data saying which people were or not were vaccinated against COVID. And when the person was coming in the pharmacy and you were printing his name in your computer, then you had a pop out if the patient was not vaccinated against COVID. Just that the pharmacy addressed us with him and discussed, would you like to be, hey, are you vaccinated? Oh, they're not. Oh, why? And discuss with him. And just this action increased the number of patients in Belgium that were vaccinated from about 5%, what is already excellent. So you see, the awareness is very important. And of course, it's much easier if you can vaccinate yourself, because it happens so many times in pharmacy that when the people are here, then you can say, hey, you're not vaccinated against flu, for example. Hey, we can do that right away. What we also do in Switzerland, we have a campaign, a national campaign with our government. And we have the day of flu, and it's decided when everyone can be vaccinated, and there are capacity on that day, the day of vaccination for the flu. We're doing that for the flu once a year. And so in pharmacy, if you have to pay your vaccination, because that's another point we didn't discuss, is the problem of who is paying the vaccination. And in Switzerland, it's like that. We can vaccinate, but the people have to pay in pharmacy, When they get vaccinated in pharmacy, they don't have to pay if they are vaccinated at a physician, because we have a problem of law in Switzerland not allowing us to do that. We are changing the law. I had a meeting this morning, so that will arrive, but right now it's like that. It's the same in Portugal. It's not the same for example, in France. So you see, if you can vaccinate and the costs are covered, then it's much more easier. So you have accessibility, but that must be paid by the governments or their healthcare insurance, because that's absolute mandatory that the people want to get vaccinated.
You raise a very important point, Martine. We cannot talk about service integration without ensuring its sustainability, and we can only do that with discussing remuneration. And I think that's a really, really good point. And that's maybe where variation is, how variation of pharmacy-based vaccination is explained throughout countries. Countries where remuneration services are in place have higher rates of pharmacy-based vaccination. And it's as simple as that sometimes. I also wanted to raise the point, going back to some of the facts you've shared, Jean-Pierre, about, I wonder not only how much do people and older adults know about the protective effects of vaccines, not only from infectious diseases, but as you mentioned, the protection of other conditions like cardiovascular, dementia, disability, etc. I'm not sure how much healthcare professionals and pharmacists know about this. And that's a really important issue, I think. We have to educate pharmacists and healthcare professionals to be very aware of all the health benefits, to increase hesitancy and confidence. And it's not just about this infectious disease or another. This is about wider than that. So what strategies do you think we should put in place to increase the awareness of healthcare professionals?
I think that I have not to answer this question. I think that Martin first has to tell me if within the education of pharmacists, you spoke about this kind of questions first.
Yes, we do. Actually, we started, with an education postgrad, because there was not in the ground education for pharmacists. And so we had a very long education with all the details, how you can persuade, how you can, what brings actually the vaccination, why you should encourage. And we did also special training for COVID. So yes, that's a part of the training. And now we take that at the university level. So all the students are.
Yes, but the question of Lina was concerning the non-infectious disease, non-infectious effect of vaccine. Are you speaking of it?
Yes, we do. Okay. We don't have, that's what I noticed with your presentation, because I thought, that's something we didn't talk about, but cardiovascular disease dementia was not. You said it must be confirmed, but yes, and pneumococcal vaccine, for example, for an antimicrobial resistant, yes, that's something we do.
So I think that you have your answer, Lina. but I think that a few healthcare professionals know already about these kind of questions.
Thank you so much.
You have to remind people, because when you're in the pharmacy, you forget to tell the patient, hey, don't forget, that helps also against this disease.
Thank you for that, Martine. I have a couple more questions left, and we have about 10 more minutes. But I just wanted to ask, maybe going back to you, Jean-Pierre, and then going through the panel, about what your thoughts are on vaccine co-administration and how that impacts uptake.
I think that it's a very important question, because WHO now, but not all the countries, are saying that we need to have COVID vaccination. COVID vaccination can be co-administered with flu vaccine, so one shot in each shoulder. And I think it is exactly the same for COVID vaccine and pneumococcal vaccine. The main problem with this kind of vaccine is that indeed COVID and influenza vaccine has to be people has to be vaccinated every year, while with the pneumococcal vaccine, it is a delay of 5 years. So it's quite confusing. But I think that if the new campaign is to have 2 shots of vaccine at the same time, it will be easier for everyone to get the vaccines and the flu vaccine. We have not to forget that, as I said, respiratory infectious disease in old adults are really killers, not only killers, but also pathology, infectious disease, which increase the disability of old adults. So vaccination are very, very important in old adults.
Thanks, Jean-Pierre. Katrina, what about your perspectives on vaccine co-administration?
Yeah, I totally agree. I think whatever solution we can have that makes things easier for everyone, why not do it? If you have somebody at the pharmacist and you're able to give both shots, that's great. So I think the only thing is to make sure the communication is clear, because I do think some older adults, that is sort of an issue, is they don't fully understand what does the COVID shot protect me against the flu shot and vice versa and things like that. So I think that's something that we've certainly seen in kind of in some of IFA's work, is that there's sometimes that confusion. So I think if the communication can be clear, great. Why not increase access in that way?
And and just to add, I think certainly it seems to me, in the UK, we have had for a long time campaigns where GPs have worn T-shirts that say, "You've had your flu jab, get your pneumococcal jab now as well," and it seems to work, because actually people don't want to go in twice. So as long as it's safe, then we should be looking to reduce the amount of hassle people have. I think one challenge for pharmacies, the UK does flu through pharmacy brilliantly, but for example, with pneumococcal vaccine, at the moment you can't do that through pharmacy on the NHS. You have to do it privately. So actually, you can't, you're not going to get someone coming in and having their flu vaccine for free, let's say, and they're in their 70s, and then wanting to pay £70 for a private pneumococcal when they could then go to the GP and get it for free. So I think it's really important that we make sure that pharmacies in the UK and other places, if we want people to co-administer, then pharmacies have got to be allowed to co-administer on the same basis.
Absolutely.
Right.
And at least for flu and COVID, the guidelines are clear. WHO have said that co-administration of these two are very safe and supported by evidence. And I just wanted to use this opportunity to say that FIP has just issued guidelines for pharmacists on co-administration that are aligned with WHO. And I think, David, you bring up another good question. This is all linked to service integration, and it has to be part of the healthcare system and the services delivered by pharmacists. And we can't have this discussion without understanding what services are being delivered in pharmacies. I have one more question. We spoke about co-administration. Let's talk about, if we are going to deliver one single vaccine to older adults, what is the most important one? This is a dangerous question, I think, because we don't want to be reductive and undermine any of the others. But maybe this is about evidence, Jean-Pierre. Which would be the most critical infectious disease that we should try and protect older adults from? And I'll go around, starting with Jean-Pierre.
It depends on the timing.
Yes.
It depends on the pandemic. So I think that the question cannot be solved. If the pandemic is decreasing, and I hope that it will be the case, but if there is no new variant, I think that flu vaccine would be very important. And what is also very important that we did not mention it, but I think that the repetition of vaccines protects better than to get once a vaccine. The repetition of flu vaccine every year is better already. But I think that I cannot tell you, I cannot answer your question. It depends really of the circumstances. But today, I think that the co-administration is probably the best way to go into this field.
Just to say, I absolutely agree, and I think you can't really pick one over another. Although, of course, during the COVID pandemic, it was very clear that was the one that we should all be having. But and still remains extraordinarily important. I think the one thing I would flag is actually, clearly, as an enthusiast for all of us getting our, flu and pneumococcal and those vaccines that are specifically targeted for us, in old age, herpes zoster as well. We shouldn't forget that actually there are a number of routine vaccines where we may have lost some of our protection because we had it 60 years ago. So, for example, things like pertussis, pharmacists, where there's growing evidence that we're starting to see whooping cough in older adults, and extraordinarily important that understandably, if you had a vaccine 40-50 years ago, it may not work as well. So I think we need to not forget about some of those other life course vaccines, and as we're now living into our 80s and 90s and beyond, we can't rely on vaccines we had when we were 3 months old still working.
You are completely right, David. And I think that perhaps one communication in this way could be also to stimulate grandparents to protect their grandchildren.
Yes, exactly.
Martin, would you like to add to that?
Yes, I thought that's very important. That's what we discuss. We say we try to sensibilize our pharmacists to tell the grandparents. Don't forget to tell them, hey, if you get vaccinated, you protect your grandkids, and that's something healthy.
Absolutely. And Katrina,
Yeah,
what do you think about single vaccine? Or maybe about prioritization, let's put it that way.
I totally agree with it. It's an impossible question almost. I mean, I'm not an epidemiologist, so I suppose if you were thinking about it from a health system lens, maybe you're kind of looking at cost benefit and things like that. I don't know, but I do think it's sort of an impossible question, because really the goal is to have an infrastructure set up where you're able to get all of these vaccinations that we've been speaking about. So I think I think I'll defer to some of the epidemiologists and things like that who might have more expertise on that. But yeah, I think really the important thing to note in that is, let's create a system where all of these vaccines are available and accessible, and pharmacists we've been speaking about are for sure a way to do that.
Absolutely. Well, I'd like to finish with a last question, and we always love to end with actions and next steps, and with you as experts with us, I'd like to ask, what action point would you prioritize, or would you at least tell us we should prioritize as FIP to increase uptake of vaccinations in this special risk group? I'm going to start with our pharmacists in the room. Martine, what action should we prioritize?
For FIP?
Mm-hmm.
Education as information for the pharmacists to give the right message that it helps to prevent diseases, or it helps to prevent other problems. That's the first point. And help and giving advice is good example from different countries, to countries that have to go to the government to help them getting the vaccination in pharmacy, and also helping them with the education of the pharmacists.
Thank you, Martine. I'm going to go across the room in the order I see on the screen. Katrina.
Yeah, I think the key thing is making sure that pharmacists are able to be vaccinators. And so, as Martine mentioned, any advocacy kind of tools that have worked in the past to ensure that the regulations are there for pharmacists to perform this task, and the free of cost issue. Why should you have to go to the GP to have it remunerated? So that's a starting point. And then I think there's an important communication piece around pharmacists as community members. And I think they can be champions in a different way than other healthcare providers can be, because they're, down the street from you, they're your kind of local, maybe you have a more one-to-one relationship than with other healthcare providers. And I think there's something really powerful in that ability, that maybe a more personal relationship that can help champion vaccination and can really be a trusted source of knowledge.
Thank you for that, Katrina. We'll pass on the messages. David.
One thing for me, I think pharmacy has to sell itself as being a really, really accessible option. And to give you an example, in the UK, you can book your flu, as I've just done, your flu vaccine online using an online website for pharmacies. You can't for GPs, you know, and I think pharmacies can absolutely lead the way across the world by basically making their services as accessible as possible, and almost shaming governments and the health services into improving their services.
Thank you so much, David. We'll do that. And Pierre, last but not least, we started with
Okay, I think that my message was that education is of healthcare professional are probably the most important things, because when a healthcare professional, whatever the level of healthcare professional, is giving advice, the people get more vaccination. I think that, as said by Karina, now pharmacists are the champions in vaccination. But we have also to think that they have to drive all the other healthcare professionals in the same way to be able to have a kind of community vaccinators which are able to increase the uptake of vaccine. We have very good vaccine, but they are not used. So it's a main problem. And pharmacists contributed a lot in this way, and they have to enhance their action to the other healthcare professionals.
Thank you so much, Jean-Pierre. And with this, I'd like to thank you so much for these important messages. This is a very, very important topic for us. And I've just entered into the chat a link to a microsite we have that gathers all of our work on vaccination that FIP has done. So for all of the pharmacists listening in and healthcare professionals, please have a look at all of our resources. And all of our work is always informed by the actions we identify in such activities and webinars today. So we continue to push our work and advocacy in this area, evidence publications, to support pharmacists deliver more vaccines. Vaccines save lives. Pharmacists can save lives through vaccines. Thank you so much to David, Katrina, Martine, and Jean-Pierre. It's been a pleasure to have you with us today, and we look forward to engaging with you in future activities. Before we completely close, I'd like to announce the next event and final finale event in this series on vaccines and special risk groups. Next episode on the 14th of November will focus on diabetes and will coincide with World Diabetes Day. You can scan the QR code you see on the screen to register for this event. We look forward to seeing you there and all our other events by FIP. Thank you so much. Have a good day. Bye for now.
Bye.
Bye.
Thank you, everyone.